May I now call Dr. Kumudini Jayasinghe and Dr. Suranga Manilgama to chair and conduct the next session, the Veterans Fire.
Good afternoon. Welcome to this important academic event of the SIMCON 2023, the Veterans File. This is chaired by the President and the President-elect and the Congress Chair, Dr. Suranga Manilgama. And I will invite my co-chair, Dr. Suranga Manilgama, to introduce the speaker and also about this the topic today.
Thank you. So I'm honored to introduce Professor Emeritus Professor Rifdy Mohideen. He's Emeritus Professor in Medicine from the University of Rohingya, and he's a senior consultant in internal medicine, and he's a veteran in the field of medicine. And he would be talking about his experience through his clinical career. And without much ado, I will hand over the podium to him. Over to you, Professor Mohideen.
Thank you very much. And also let me also thank the President and the members of the Council for asking me to share my experience under this presentation. Okay, so what I've done is I'm going to share with you 4 challenging cases that I can recall being a veteran, and also those cases that actually has taught me lessons. So I will highlight what those were. And in the early years of my training and also as a specialist, I must say they were all near misses. So there was no great diagnostic errors that were made. And also included in this presentation is a serendipitous encounter while in training overseas that led to a research study. And again, as I said, I'll highlight what I've learned from these cases. So the first case was in Gaul, in Teaching Hospital, Karapitia. I was covering up for the registrar in another ward on a very busy casualty day. So the house officer asked me to see a young woman around 25 to 30 years old, I can't remember the precise age, with hypertension, and this house officer has already done an ECG which shows widespread T inversion. So the working diagnosis was a myocardial infarction. Mind you, these are 1980s, right? 1980s. So, and they were managed conservatively. So I was asked to see this patient, a young woman, hypertension, and ECG changes. So what could be the differential diagnosis? Clearly, a myocardial infarction is in the differential diagnosis with hypertension or cardiogenic shock. If this patient had cold extremities, sepsis, though in spite of the fact that this patient did not have fever, could have been an occult bleed. There was no history to support it, but that should also be considered. Was it Addison's disease? So that's another possibility. Or was hypothyroidism, accounting for the ECG changes because it's widespread T changes, and also with some additional qualification. So, so these are things that would have run through anybody with this kind of presentation. But I reviewed the history in this patient because the history was not taken very adequately, being a busy night. But I took a little extra time trying to get the history from this patient. She was a mother of 3 children. She has had no cardiovascular risk factors to account because she's a young lady. No family history of heart disease, and not had used oral contraceptives. So the risk factors are pretty low in this one. So we had to look for something else other than a vascular disease. So it turned out that her last child was born 3 months back. She had a difficult labor, and blood transfusion was given during the childbirth. She has not breastfed the child due to inadequate breast milk, and had had no period since the childbirth. I know what you're thinking now. So she was comfortable. Mind you, she's myocardial infarction. She was not in pain. She didn't actually complain of chest pain also. She appeared a little pale. She had a pale, dry skin, warm extremities, so sepsis and so on was less likely. And she had no absent pubic hair and armpit hair. Of course, she had a delivery, so they would have shaved that area, but it has not regrown. So this was a case of Sheehan syndrome. So she was managed, so I asked this house officer to draw blood for hormone studies. Mind you, there were limited availability there, right? You could just do the basic ones. She was given hydrocortisone before subsequently giving thyroxine. Later, she was actually lost to follow-up. I just tried to check whether what happened to this patient. And I encountered one more patient with a similar presentation with an experience of having seen this patient before. So what are the lessons that you learn from this? So the case underscores the importance of history taking above all other types of evaluation. Needless to say, history is so critical in this kind of patient. And one other thing I want to emphasize is the importance of menstrual and obstetric histories in history taking. All women should have a very detailed, because what happens during obstetric period becomes a risk factor, particularly if somebody got hypertension, diabetes, that turns out to be a risk factor for hypertension, diabetes in adult life, and also a risk for coronary artery disease. So as also it's uncommon for young women to have coronary arteries. Not that they can't get, it's uncommon, right? But so you need to look for other alternative diagnoses. And also consider Sheehan syndrome in a woman of childbearing age, presenting later with hypertension after recent childbirth. So that was an interesting case. As I said, I've seen one more case after that. Okay. Now the second case, which I like to share is, in the middle of 2013, February, a group of 31 adult males and a child who survived a 2-month boat journey were rescued by the Sri Lankan Navy and brought to Teaching Hospital Karapitiya, Galle for emergency medical care. We were alerted that there's a group of seafarers who've got lost, and so we were prepared. I was the physician on that day looking after the ward. So actually it turned out to be they were refugees from the Rohingya community, a threatened minority group in Myanmar. They had exhausted their food supply and left to starve in the last several weeks prior to rescue. Actually, they were, it was like a 2-month boat journey. They were going to go from wherever to Australia. So they were picked up by the Sri Lankan Navy from the coast of somewhere near Trincomalee or some place like that. On arrival, they were screened for dehydration, hypoglycemia, malaria, violent injuries, and medical emergencies. So we did that. But in those 32 individuals, there's one case that was causing a little challenge in order to find out what's wrong with this patient. This is a 20-year-old male who complained of weakness of legs, blurred vision, and leg swelling. So on examination, he had bilateral pedal edema, proximal muscle weakness, bilateral foot drop, and disc edema on funduscopy. Yes, we do ophthalmoscopy routinely. Investigation revealed mild renal impairment and mild hypokalemia. There's no evidence of any cardiac, liver, or thyroid disease. So this patient was managed as at the best available thing was looks like an acute renal injury, but his overall condition did not improve. The communication was a huge barrier because they spoke a language that nobody understood. And we didn't know what these previous health issues were and what happened during that boat journey. Luckily, a Buddhist priest was available who had actually visited Myanmar many years ago, who acted as a translator. So we got down the Buddhist priest who actually got a bit of information. Then it transpired that they were the extreme starvation actually, because they had didn't have any food for one whole month, because they expected to be, in Australia for earlier than that, so they exhausted their supplies. So a diagnosis was suspected subsequent to that information obtained by that priest. He responded dramatically to thiamine with clinical and biochemical improvement. So laboratory confirmation of vitamin B1 deficiency, of course, could not be. So here was a case of beriberi, thiamine deficiency, right? Because even if you have brought in food supplies, and if you don't store it properly, the thiamine amounts in those foods can also get depleted. So, here, this is the patient that eventually got treated and actually got completely well. So that was, and here is the priest who helped us communicate with this patient. So, this whole thing we reported it. Actually, I presented this case, this series of cases in Perth, Australia, at a conference called the Transcultural Mental Health and Second Australasian Refugee Health Conference in 2013. And there were several other interesting ones. I had a patient with tropical myositis as a second interesting case among this, because they were all, packed like sardines in that boat. And that's another complication that these patients actually had developed. So what lessons have we learned? Barriers to communication, mandatory judicial processes, and a lack of clinical protocol hampered an earlier diagnosis. Because when it deals with refugees and these kinds of problems, we don't have a set way of really assessing and screening them, right? So this experience highlights the need for systematic, coordinated approach for the health care of refugees in the emergency phase and beyond. Mind you, this may not be the last set of people who might be at your doors during these troubled times all over the world where refugees are on the increase. Now, the third one is a simple problem, but it again taught me an important lesson here. Here was a 50-year-old male school teacher from Gaul. He had been treated with statins by the cardiologist for several months for hyperlipidemia, right? Not surprisingly. Within 4 weeks of starting treatment, this patient began experiencing lower extremity myalgia and cramping, which he attributed to chronic lumbar disease. Lipid levels were not normalized, despite a further escalation of the dose at the next visit. So here is a patient who's got statin, developed these problems. So on examination, this patient had a little bit of facial puffiness, slight tenderness in the calf, and nothing else. So thought about statin-induced myalgia or myositis, investigated further, and to this, not too much surprise, but his TSH was markedly elevated. So here is a case of hypothyroidism. And why I highlighted this case is this is a common thing that we encounter. We may miss hypothyroidism in the evaluation of hyperlipidemia. So what did we do? We stopped the statin, started on thyroxine and titrated up to about 200 micrograms. He required about that. Follow-up showed normal lipid levels. Muscle pains were reduced, and lipid-lowering therapy was not required in this patient on follow-up. So always exclude a secondary cause of hyperlipidemia, particularly hypothyroidism, because we are very quick to give statins whenever the lipid. We don't check anything else. Everybody gets a statin when there's a marginal rise. And it has changed my practice. I always would do a TSH before I start statin. I've learned a lesson from these kinds of patients, and there have been several other cases that have been detected, right? So that's good practice. If hypothyroid, do not start statin until the thyroid status is normalized with thyroxine, right? So because it can cause up to even a rhabdomyolysis in some situations if you give a statin. And if you don't treat the thyroid, you don't make it euthyroid. Okay. Case number 4 So this is an elderly lady, around 70 years old, who presented with fever, right-sided abdominal pain and urinary symptoms. She looked ill. She had some tenderness in the right flank. A provisional diagnosis of urinary tract infection, treated symptomatically and with empirical antibiotics. Urine analysis revealed presence of red cells. So we revised the diagnosis, okay, UTI, but with probably renal stones, right? So the next day, the patient did not improve. Radiography for stones was negative. These are all 1980s stuff, you see. Full blood count was repeated and showed some leukopenia and low platelet count. Repeat full counts on the next day continued to show a low platelet count. NS1 antigen was not available for testing those days. So because of this, we checked her IgM dengue antibodies, which turned out to be positive. So it's a case of dengue fever it's an elderly patient presenting with abdominal pain and hematuria, right? And those days, unlike now, we don't suspect dengue fever in elderly people. They were confined to most of the presentations in the young age group. So that is why this particular case was overlooked, right? And you consider other diagnoses instead. So I think you should include dengue fever in all acute febrile illnesses if the symptomatology actually fits in. So that's the other lesson I have learned, to keep a low threshold for the presence of dengue. Now, this is an interesting situation, serendipitous finding, right? I was training in the UK, trained at John Radcliffe Hospital in Oxford in 1986, 35 years ago. I was part of a team that was looking at a validation of a Doppler machine. My colleagues have bought a new Doppler machine to look for aortic flow velocities. And I was one of the subjects of the validation. So they asked me, Rifdy, you better come. I want to check because they want to see whether the machines are. So I was asked to come back again for repeat measurements. And they were significantly different. And they were worried that these machines, something wrong with the machine, right? So I told my colleagues that I was observing the Ramadan fast, being a good Muslim, on the second occasion. The first occasion I was not fasting. Second occasion I was fasting. And in the British summer then, it was a 16-hour fast, right? And so what does fasting do to aortic blood flow velocities? So as a result, at least they were relieved that something wrong with me rather than with the machine. So we planned out a small study to test out this observation while on a low calorie and a high calorie intake. So we randomized 9 subjects to a crossover study with either low calorie changes to the sympathetic nervous system. So we published this, at least we presented this as abstracts. You see the 2 abstracts on aortic blood flow changes during low calorie and high calorie intake, and also the ambulatory blood pressure responses during this period. So the take-home message in that was low calorie intake was, as opposed to high calorie, can lower systolic blood pressure and aortic blood flow variables. And these changes are probably mediated through the suppression of the sympathetic nervous system. Now, up until then, I didn't realize that my understanding was if you fast or you don't take any food, your sympathetic nervous system actually increases. Contrary to that, the sympathetic nervous system tones down. Because why should it expend energy when you don't have calories? You see, so actually this is what happens. There's a suppression of sympathetic nervous system during fasting. And this has been shown in several other things also. So, but more importantly, trying to say that research ideas could start with the serendipitous discovery. You know, by chance, you might observe something, and then you might want to test that out. And in fact, what they say is about 50% of scientific discoveries are following chance discoveries. So, in summary, I think we make mistakes, and we are, as a result of being human. So what I presented to you was 4 cases that represented near misdiagnosis or salvage diagnostic errors. And diagnostic error can be mitigated by eliciting all relevant information. So you must get both history, examination, and if there is available laboratory data. And include what you have learned, the lessons learned in a reflective cycle, so that you have come across that, you make sure it doesn't, you reflect on that, and inbuilt into your system, okay, I encounter that once more, I would adapt it and fit it into our clinical practice so that it doesn't trap you again during these clinical encounters. Thank you very much for the opportunity.
Thank you very much, Prof. Mohideen, sharing those clinical experiences with us that you have shared with us 4 interesting 4 case histories, the unusual and atypical presentations of Sheehan syndromes, thiamine deficiency, hypothyroidism, and dengue, and the last one, of course, your research observations. So thank you very much, and the questions are not included in this. So we thank on behalf of Sri Lanka College of Internal Medicine, so sharing your experiences with us.
Thank you.
On behalf of the Sri Lanka College of Internal Medicine, to accept the token of appreciation, the certificate, I would invite President Dr. Kumudini Jayasinghe to present the certificate to Professor Mohideen.
Thank you, everyone.